Hi, everyone. Welcome to Ardexia and our series, Speaking to Clinicians from Around the World. I'm Dr. Aditi Joshi, and this is where we cut through the hype to explore healthcare innovation that actually works. Each episode, I talk with leaders, practitioners, and other people who are digital health leaders who are working on digital transformation, telemedicine, AI, system change, and whatever else to make healthcare better. We share real stories from the trenches and practical strategies for creating healthcare change that people can trust. So let's dive in. Today, I am really happy to have my friend and old colleague, Dr. Nadeem Alduaij, who is a physician executive, digital global health innovator, and connector at heart. He currently serves as a consultant for the Research and Innovation Center at the Department of Health, Abu Dhabi, and is co-founder of Baraka Impact Finance, a Swiss global health impact investing advisory and data analytics platform. His 20-year career spans 3 continents, including roles as co-founder of a digital primary healthcare company, chief of emergency medicine in Kuwait, and associate chief and instructor at Harvard-affiliated hospitals. He completed his clinical training at Harvard-affiliated BIDMC and Harvard Medical Toxicology Fellowship, and holds an MD from the University of Geneva and an MPH in Global Health Policy from Harvard. So it should come as no surprise that Nadeem is very worldly. I worked with him in Abu Dhabi, and it's so nice to have you here, and thank you for joining me.
Thank you so much for inviting me, Aditi. It's lovely to be here.
Great. So Nadeem, we've had many interesting conversations, but, I want to talk first about just your experience in Kuwait, which is before, obviously, your experience in the UAE, and just walk us through the virtual first patient-centered system that you helped build there.
Yeah, so this was during COVID. We partnered with some young entrepreneurs who were interested in building basically the startup ecosystem for Kuwait. They launched this venture builder, and they wanted to work in health. I think everyone understands that there are challenges in Kuwait. The largest chunk of healthcare is operated by the public sector, so the Ministry of Health, around 80+% of healthcare. So all the major hospitals, and then you have a smaller private sector in healthcare. And one of the biggest challenges that we face in Kuwait, but also in the rest of the Gulf countries, is that we have a very rapidly growing chronic disease burden. And that's really, to me, the inflection point was the Gulf War, but it was really kind of starting in the late 70s or 80s, and then really exploded in the 90s and early 2000s, where despite our national investments in the healthcare infrastructure, we had this growing burden. To me, the problem was that there was a neglect. There was a deficit in primary care, right? In my practice and in what I was hearing from family and friends is that they'll go to specialists for every condition that they have, whether it's a minor headache, they'll go to a neurologist, they'll go to a cardiologist for palpitations or anything related to cardiovascular symptom. And as a result, you have this growth, right, of the subspecialty space. And the primary care, although we do produce incredibly smart and really evidence-based practitioners in family medicine, it's one of the oldest and still one of the best residency programs. They just don't work in the environment that allows them to fully practice primary care, right? So really holding on to a patient and his or her family, for their entire lives, and providing the preventive care, good chronic disease management care that is needed. But there's a lot of referrals to specialty, and so the idea was, can we in some ways make primary care sexy? Because we like things that are attractive, right? That are tech focused. That there's a huge emphasis on technology in healthcare in Kuwait and now in the rest of the region. And so I thought, why don't we build a platform, a telemedicine-based platform that would connect users through this urgent care service that we produced. We needed an entry point. And we had a couple. One of the entry points was urgent care. People don't want to go wait in a busy ER, particularly that most of the ERs are filled with non-urgent complaints, right? There was a study that was done by some of my colleagues several years ago where they found that 70 to 80% of patients in an ER have non-urgent complaints. All can be dealt with at the primary care level. So we said, why don't we work on that segment and try and cater to them through a virtual urgent care? And that would be an entry point where patients would be then connected to a family physician that would be answering actually those calls. And then there'd be a follow-up call where they'd try and create that bond and answer the patient's questions, get, deep dive in their history and try and get them hooked into the system where they would just need one provider to take care of their hypertension, their diabetes, their hypercholesterolemia. And so that was the idea behind it. We wanted to integrate artificial intelligence ultimately because we knew that we wanted to automate care. We wanted to put patients into care pathways. So as time went by, and as we started hearing about artificial intelligence coming up, coming online soon, we were like, can we create ways to automate care so that patients get placed on care pathways, whether it's a preventive care pathway, whether it's a diabetes care pathway, et cetera. And that would then automate the labs that would be ordered every year, their screening programs, et cetera. We had, our system was connected to pharmacies and labs. So we would have pharmacies deliver directly to the homes. We had lab even come to your home to perform the testing in many cases. And so to make things a little bit easier for the patient, but all the while building that bond. To me, that was, and it goes back to trust. I think that's one of the big issues is we lack trust in the system because we get bounced around a lot. When in fact, most people will just need one provider. And that's what we try to build using technology.
Yeah, and I think the primary care portion that you're talking about, this is a problem everywhere, right? We don't have enough preventive care, public health in many places. And it sounds like this was helpful because it actually overcame some of the cultural parts, right, of the medical system because the culture informs the medical system truly. And so now that you've moved to the UAE, do you see some of the same problems within at least primary care? I know you work in a different space now, or do you find that you're seeing similar types of issues and challenges both in primary care or even just with implementation of other types of programs?
Yeah, I think they're very similar countries. I mean, culturally, we're very similar, right? The Gulf countries, we all have similar backgrounds. We come from the same places. And the way we've, built our nations, right, over the past, several decades is very similar. And so I think the expectations are similar. This is what I'm seeing here, right? Patients, want a quick fix. I mean, we're seeing that in many places. We're seeing that in the US and elsewhere where people want a quick solution to their problem. They want to have access. They want to get a test done. They don't want to be waiting in line. They don't want to wait weeks for an appointment. And so I think we feed into this, right? We give them because we have, if you look at the number of hospitals, you look at the number of beds, we're on the upper limit, right? When you look at WHO recommendations, we are above that limit of bed per population. And so there is an excess number of beds. And so hospitals are competing for those patients. And so there's a lot of technology that's being thrown around. Every hospital has its app. Every hospital has several, tech solutions, right? Whether it's an EHR or you name it, RPM programs. And so ultimately the problem is the same. No one here has a family physician. No one has a primary care provider. Some of them have it on paper because their system, now mandates that they have a designated primary care doctor, but someone they've probably never seen because they want to walk into a specialty clinic. There's this impression that specialists are better in terms of diagnosing the problem, even though they don't recognize. And I'll tell you, I think one of the big challenges that we have that's very specific to the region also is that the term GP, general practitioner, in the UK, it's a family physician, right? It's someone that's trained for at least, 5 years or so in family medicine that can manage pretty much every disorder. And so primary care has had this bad reputation because they assimilate the GP with primary care and they say, but these are not trained doctors. And I want someone who understands, who can examine me. So we end up going to those specialists. And yet, like in Kuwait, we also have some fantastic family physicians here. There's at least 20 to 25 family physicians that graduate programs here every year. So there is a supply. It's just, again, being able to prioritize that at the health system level, right? At the regulatory level where, and that goes back to financing the system and where does, the financing go preferentially. But yes, I'm seeing very similar problems here with primary care, and the burden of disease expresses that, right? We collectively, the Gulf countries are the most burdened in terms of obesity, diabetes, etc.
I was really surprised to hear about the obesity statistics where you said that Kuwait had the highest obesity for children. There's a lot in what you just say that we could follow up on. But, I was thinking about when you're talking about even using specialists versus primary care. First of all, when you can attest to this, right? And most specialists or doctors out there can, that whatever you train is actually how you see medicines. you're also emergency medicine. So for us, we see a patient, the first thing our brain probably does is what is going to kill that person? And then we bring it down. Whereas a primary care doctor, they're actually trained to see a holistic, comprehensive picture of their patients, which is very different and which is very needed for long-term care from, birth to death, which is what you need in that. And it's interesting as well, too, that part of what you're saying is that it is just a remnant of the way that primary care was looked upon or the way it was trained. It's like a nomenclature problem that's also making this happen. And those are always harder to overcome and it takes time, but it can happen. So going from there, one thing that we talked about, and I find this really fascinating is, I know you're also a toxicologist. You're looking at building out the poison center. You are building out the poison center in Abu Dhabi. And just when you're looking at digital tools, you mentioned that sometimes when looking at digital tools, most of them are not meant to be implemented within other places. So I really like to hear more about that. What's that experience like? And so I'm from the US, as you know, and so most of these tools are built for the US market.
Right. So that I think is one of the big problems that we're facing is that we have a very unique population, right? These are countries that have amassed a lot of wealth or in very little time, right? In a few decades. So we are, we're building infrastructure, we're building very advanced systems in every sector. And I think what we're seeing is that we're seeing a lot of the the health tech world, coming here saying, well, we can sell you these really incredible solutions, whether it's EHRs, whether it's AI, based systems. Now it's, of course, the big thing. Everything has to be AI, right? And that's, I think, one of the great things of this country and this society and this leadership is that they're incredibly forward thinking in terms of we need to build. And this goes back to the founder of the UAE, Sheikh Zayed, who really said we need to advance our society and we need to be open up. We need to the rest of the world. We need to bring in the best minds to build a sustainable society and an innovative society. And so this innovation-based government and leadership process is critical to, how we've become what we've become here across the region. I think specifically in the UAE, because it sits apart from the others. I think because of that history and that mindset that's been ingrained in everyone living here. But there are things, and we're seeing it now, right? In the literature, the AI literature, where we're seeing weird bias, where we're seeing all those things that tell us that, oh, wait, yeah, those things are very sexy, they're very cool, but they're trained on specific populations, and maybe this is not going to work in Africa, maybe it's not going to work in the Middle East. We want to offer something much more advanced, much more technologically. We want to create a tech-driven society, and so I think the implementation is a challenge because we're now seeing, for example, in Abu Dhabi, there's more than 40 EHR systems across the health system, and we're talking about a population of 4 million, right? So imagine like what that creates in terms of interoperability, in terms of when doctors move around or providers move around to other systems, the learning curve, so that creates a lot of different challenges. And also similar to the US, we have a specific reimbursement system, and we have in Abu Dhabi a private insurance system. There's several insurers. And so, putting all this together, making sure that the providers are inputting good data in those EHRs that is going to be usable at the population level. Sometimes that's challenging, again, because of the incentives that the hospitals have, the incentives of the insurance, and then the regulation on one end that is trying to push very fast, very aggressively for these tech solutions to be adopted and implemented. So can they be implemented in this particular environment that is very, very unique? Yeah.
That's really interesting. So, I always say, and I just realized I'm always saying that tech isn't the problem with adoption, but maybe sometimes it is if it doesn't actually fit into the context or the healthcare system exactly. But then again, it can be tailored to and should be able to be tailored into those cultural contexts, right? So that they're usable.
Yeah.
It would be impossible to share data or understand people's status if you're constantly having to find and share within different contexts. And just, one quick follow up on that. Is it because that they're not working, or is it just you're saying, is it a due diligence? What do you think is like the reason that there's so many different tools?
Well, so one is we have a privatized healthcare system. So, and you have these different systems, right? So you have NMC, you have Mediclinic, you have all these private groups. Some of them are international, some of them are local, but they come in. They come either with their legacy systems, or they end up purchasing their own systems, depending on who the owners are, where most of the providers come from. So there's a lot of reasons why you end up with such a convoluted system. And I think, and they're very different, right? So you have some that have Epic, right? Okay, and you have others that have Cerner, or and then you have systems that were built internally. You have systems that were built in the East, right? India, China, etc. And so you have this salad bowl of different systems, all with their different limitations, right? They come in from different places with different purposes, right? Even though the goal is to capture patient data, the way they're built, like Epic was built really for the admin, requirements of the US, the insurance system of the US. And so sometimes those don't all fully work. So you're right. Many components will work because the basic clinical stuff is relatively similar, but then all the rest of it, the admin, legal, financial systems don't necessarily work in the exact same way. And so there's that. Of course, there's always a human capital issue, because you have, as I said when we talked earlier, is that we have providers that come from all over the world. They come with their degrees, their training. Many of them will just qualify for a license, right? Depending on where they come from. Others have to pass an exam. But it is not like a one unified system, right? So people come in from Europe with their own training. They don't have to adapt to the local system in any way. And so you have this mixture of providers with different mindsets, different narratives, different backgrounds that now have to adapt to this new population. And so it creates a challenge in terms of implementing systems that are, for example, very convoluted, very technologically advanced, where it requires a pretty significant effort to get used to. And so I always recommend, I said, look at who you're catering to, who's going to be using this every single day, and make sure that whatever solution you're adopting, the lowest common denominator provider or user can easily be trained on it, right? It's a simple training process versus, making the mistakes, making the recurrent, yeah.
Yeah. It's interesting too, because we were talking earlier too that, it's not always the same, not even just a cultural context and the tools, but, maybe it's a little bit different. So, one of the Ardexia pillars is on clinician mapping. And what you're partially describing is adoption readiness. I mean, there's many parts of it and it's very complicated. But, I want to ask you a little bit, dive into a little bit more of this connector philosophy in the last few minutes. But you're a connector. You've worked in horizontal, agile, multidisciplinary teams. And very uniquely, you've worked in multiple countries
Yeah.
in healthcare, in medicine. So that's very, very interesting just to me and most people, I'm sure everyone listening. So when you're looking at how to adopt innovations, how do you break down barriers regardless of where you are or what the healthcare system is like? Are there similarities? Are there differences? Or are they basically the same things that you have to do to make yourself that connector?
So I think inherently, I've always, throughout my life, I've always been one to critique and criticize dogma and processes. And I think this was from my time in the US. I was very fortunate to work with folks that were incredibly forward-thinking, open. I was so lucky to be able to work shifts with Peter Rosen. And when you're sitting there in the middle of the night working with the godfather of emergency medicine, and you're calling him Pete, right? And that stayed with me, right? So I brought this back wherever I went, whether it was back to Switzerland, where I spent most of my life, or here in the Gulf. The first thing is I tell people, don't call me doctor, right? Just call me Nadeem. That's the first step, because, and I say that's the way I've always practiced, but I always tell them that there's a scientific reason, right? That 60 to 70% of medical errors are related to communication challenges. That to me is the first layer, right? Is being able to open up and say, let's all work at the horizontal level, at the same level. We talk freely, right? That's how we're supposed to be practicing in emergency medicine, right? To save lives and to help patients. But also when you talk about implementing innovations or technologies, you need to be able to come down to that level and say, what are the challenges that we're facing? How can we solve them? Can this solution help us? Instead of just kind of defending ourselves with our egos and saying, I know better. And so I think the across continents, I think that to me, the hierarchy, right? And I saw this in Switzerland where we still have a lot of layers, and it's really hard to get people to sit down and to agree to something. It's always a top-down issue, and that's tough for implementing. It's tough for the ones at the the junior level to then accept things where they don't see value for themselves. They think that this is outdated, or there are better ways of doing things. So we see this I think at the level of the administration, whether it's at the clinical level. There's a problem with communicating fact, communicating openly, and there's a real challenge in identifying the evidence. And when I say that I'm a connector at heart, is I've always looked for the evidence. I said, show me the evidence that this works better than something else, right? I'm willing at age 50 to change my practice if I read evidence that I've been doing things in the wrong way. That allows us to then open up to using new tools, right? Okay, let me start using AI to optimize my efficiency, my productivity. Let me find out, and I'm getting into this now and trying to better understand. But I really think that we live in boxes, and I think it's really frustrating to me to think that physicians, doctors, providers in general are in a box. We have a hard time stepping out of this box and taking that risk and saying, okay, yeah, I don't know everything and I need to open up to something new now. Because that's ultimately how you'll adopt technology. That's how you'll adopt these novel systems. Otherwise, you're not using them optimally. And that's what we see a lot of. Like, okay, I have to use this thing. So, they're not going to put the effort. They're going to minimize the pain instead of really getting over the barrier and saying, I need to learn this. I need to go back to school, learn this, and, in some ways and accept it and then move forward. So I think that is something I've always tried to bring solutions, evidence to people and say, there's this other way of doing things. Look it up. But yeah. And I think it's a better way of working together and advancing, is just admitting what you don't know and moving on, right?
I love that answer. And I was going to say that even for all of us, but especially those of you in training or students who are listening, listen to that again. And I wanted to highlight some things that you said that were really important in there is that, just in general, that in medicine, you cannot bring your ego. We all know that if you do that, you bring that hubris, it will be cut down very quickly in your career because something will happen. And we have to just be very much aware that we're always learning. And that's a second point. We always have to learn. Medicine doesn't sit and say, this is enough. It is always, what can we do better? So no matter, like, let's say you have the perfect tool and it works amazing for something. I always think about this. It's like, no, it doesn't. If nobody is telling you that there's something wrong with it, you're in the wrong group, because the doctors will always tell you that there's something that can be better.
Yeah.
And I just really lastly love what you said about, we put ourselves in this box when in reality we have a lot of ways that we can give. Yes, I know that, it's time sensitive and sometimes you don't have the time, but not to think of yourself of being in that box. And that was a beautiful answer. So I know we're running out. I just want to ask you one really quick question, just a one-liner for everyone listening. So you're really focused on building health systems of the future. You've done a lot of incredible work already. But for anyone who is listening that are trying to do the same thing, where do you think they should start to create real sustainable change?
Well, that's a tough question.
I know you have it in you. I know.
Look, I think ultimately it's knowledge, making sure, because I deal with residents every day. We train residents all the time, and it's about educating them. It's about opening their minds to, because ultimately they're the ones who are going to be owning the system. They're the ones who are going to be changing it. And so to me, it's about really opening the minds of the future leaders of healthcare, right? And because we're past that age where we have our set minds, and some of us can still learn things, but it gets harder, right? It gets pretty hard. So I would say yes. I would say open the minds of the next generation of healthcare leaders. One thing that I say to every single person that comes by me that I am fortunate enough to train and to teach is be curious. And there's a fundamental lack of curiosity in healthcare, and at least at the practitioner level, I'm seeing that. And at least I think where I've been, we need to be curious, because I think as you said, things are changing incredibly fast. We need to understand these new tools that are going to make the future of healthcare, and we need to know everything about them, the good and the bad, right? And not be blinded by the flashy, the glitter and the glitz. I think that's to me is the key point is I wish everyone was curious and they would just like deep dive into everything and we probably would be in a better place, I think, in terms of moving the needle.
Great. So be curious. There's so many incredible things to learn in the world. So there's always some way you can contribute. I could ask you 1,000 questions, but I know we're out of time. Thank you so much, Nadeem, for joining me. It was such a pleasure to have you and to see you. And to
You're
thank you,
welcome.
everyone listening. If this conversation sparked any ideas about your own healthcare innovation challenges, please follow us, visit us, and see if we can help you out. And of course, join us next time for some interesting conversations with people who are doing this. We want to be able to show how people everywhere deserve the kind of innovation of healthcare that stabilizes societies and makes things better. Until next time, thank you, Nadeem, so much.
Thank you, Aditi. Thank you.